Thank you for the opportunity. So this is a case on diagnosing an early glaucomatous damage in a homonymous hemianopic patient. So in clinical practice, the differentiation of glaucoma from a non-glaucomatous neurological damage can be really difficult for even experienced observers. But to add on, what if there is a coexisting glaucomatous cupping and a non-glaucomatous neurological damage together? It makes things extremely difficult even for experienced people as well as for neophytes. So in this case, an early glaucomatous damage in a disc which had a pre-existing non-glaucomatous neurological damage is being discussed. It's a holistic evaluation along with the new Brooks membrane opening minimum rim width tool, which is currently revolutionizing the glaucoma practice. Previously, Brooks membrane opening horizontal rim width was the one that was being used, but now the novel minimum rim width is come into play, and let us see how. So the green is the internal limiting membrane and the red line is the Brooks membrane. And currently the OCT parameter is changed, and it's an evolution in glaucoma practice where the minimal distance between the ILM and the Brooks membrane is the one that glaucomatologists are recommending, and studies have also thrown light on it. So this is a normal disc where you can see that previously the traditional horizontal rim width was the one with the orange arrow on the left hand side bottom, which was the one that was taken, but now it's the blue Brooks membrane minimum rim width, which even detects a pre-perimetric glaucomatous damage. The main advantage of this technology is the GPS system, or the anatomical positioning system as it is told, where the fovea center is first marked and then the Brooks membrane opening, that is in terms of disc area, that centration is marked. The fovea BMO axis gives us a plot, so a small head tilt or even a patient who comes in follow-up, the same piece of tissue is examined at every visit, so it moves towards more better reproducibility. So this patient, a 73-year-old male patient who had a left occipital lobe infarct 30 years back, had a right homonymous hemianopia with macular sparing. He is complaining of a mild diminution of vision in the remaining field of vision, the remaining seeing area in the last 1 year. So the routine annual checkup, he also had a family history of glaucoma too, and the visual acuity is 6/9 and the color vision is normal, anterior segments are perfectly fine. And the diurnal variation is also very tricky here because when we did a phasing, the peak was 21 only. It did not cross the 21 barrier, but still we had to think in terms of normal tensor glaucoma. Both the eyes, there was a fluctuation with 12 o'clock and 10 a.m. in the right eye and left eye respectively, 21 being documented. And that is the right skewing deviation in the Gaussian distribution curve. And the posterior segment examination, there was a mild temporal pallor owing to his neurological issues, and the cup disc ratio was 0.7 and 0.8 respectively, and this is the fundus photograph of that particular patient. And 24-2 and 10-2 was actually done, and this is the visual field of that particular patient, 24-2. And this is a 10-2 of the same, depicting some more localized defect in the other area as well. And this is the Brooks membrane opening minimum rim width of OD and OS. You get up to 48 segmented scans respectively. And this is again the deep cupping seen in the right eye and the left eye respectively. So you can see here the RNFL as well as the ganglion cell layer, when the progression analysis was plotted, there seems to be between the December 2019 and March 2020, a span of 4 months, there seems to be a slight loss of RNFL and ganglion cell layer even in the seeing area corresponding to that particular structure, both in the OD as well as in the OS. So that was one particular catch in this patient. So the rationale of diagnosis was, one, the history taking, that the patient himself telling the last 1 year he has mild diminution of vision, and occipital lobe infarcts does not need to cause a non-glaucomatous cupping, that's point 2. There was a diurnal variation of IOP, not enough for a POAG diagnosis, but at least NTG was contemplated in this particular patient. The basic signs of ISNT rule being breached in this particular patient, and also the OCT documentation with inception of superior arcuate scotoma even in the other seeing area. It has crossed the midline. And this particular technology, it's one of the first cases to apply this, and it is due for publication, not yet published, with the APS Brooks membrane opening minimum rim width for early diagnosis of glaucomatous damage, even in a neurological case or a non-glaucomatous neurologically damaged disc. Thank you for this opportunity. These are my references.
Very, very nice thought, though. I mean, of course, I have never deployed it in my practice. There seem to be a lot of discussion in glaucoma circles as to how much
Yes, sir.
would you base your decision only, mainly on OCT, right?
Yes,
I mean, if you have changes in the OCT, would you go ahead and treat, or would you go ahead and act? And that's partly what
Yes,
it
sir.
seems like, because you had the variation did not really say. I would also look at the visual fields and say that the eye which had a predominant temporal defect, if they start developing nasal defect, you know that probably there is an overlay
you
of
could see that, and if that's
Yes, sir.
progressing,
overlay
then
of glaucoma on the previous neurological problem.
So it was a more holistic, not only the OCD.
I know.
Yeah, yes, sir. Yes, sir.
I guess, I mean, as we are seeing with time, technology is evolving in our understanding of information from there. The only, of course, the important thing to remember whenever we're dealing with technology is the minimum change before which you consider it significant.
Yes,
So, consistency of the change and the minimum variation before which we can take it. But I guess we are still searching for, because unfortunately there are many cases that get misdiagnosed that are pituitary tumors, and because of the excavation of the disc that follows a compressive lesion, they are misdiagnosed and managed as glaucoma, and the vice versa, pituitary adenomas which may be secreting, may result in an increased steroid milieu in the body, resulting in glaucoma. So there are patients who've been managed as glaucoma because they do have moderately increased pressures, but are progressing and they actually turn out to be macroadenomas. So it's very, very important for us to, as technology helps us to be able to, add to clinical armamentarium to differentiate between and see where both are there. So very nice. It's a very good thought, and we hope that more and more objective criteria come in so that we are able to, with more confidence,
Yes,
get this idea in place.
Very good initiative.
Thank you, sir.
One point and just one very difficult. So can you highlight that, of course, there is some openings, changing in the, is there any some pattern in glaucomatous or any neuro-ophthalmical? Is there any sense, any difference in between neuro-ophthalmical cause or true glaucomatous cause?
So that is the confusion, sir, because there is not a fine line between that and this. And moreover, to add on to this case, even the IOP did not cross 21 also. So that was even more trickier, and
Not in this case.
yes, sir.
Any way, any suppose.
Maybe not, according to my knowledge, not till now, but maybe maybe it may happen, sir, in the
Yes,
future.
definitely.
Maybe,
can
sir.
think for.
Unfortunately, life is not in black and white and
Yes, sir, it's
sharp
grey.
corners and sharp edges. So
So,
thank you.
Thank you, sir.